Hi, I am honored to present this case for Aorta Hub regarding a young woman with peripheral embolisms, a surprise in the transesophageal echocardiogram. I am Dr. Maria Celeste Carrero, presenting this case from the San Isidro Cardiovascular Institute at the Las Lomas Sanatorium, located in Buenos Aires, Argentina. Let's discuss the case of a 37-year-old woman without significant medical history, except hypertension, which was diagnosed 3 years ago. She came with good blood pressure control while being treated with losartan 50 milligrams a day. She was a former smoker, having quit the tobacco habit 5 years ago, and was a light smoker. The patient was nulliparous and did not have any notable gynecological history, and she referred to having experienced fatigue that had been worsening in recent weeks, growing more pronounced over the last few days. She went to the emergency room in the morning, referring to this asthenia and also mentioning a precordial pain, stabbing, and atypical subentrant lasting 2 hours that had occurred between 9 and 11 the night before. She denied other symptoms. She reported that the pain felt like a stabbing sensation, occurring spontaneously and not radiating. And it had eased, so by the time of the consultation, she was symptom-free. Also, during the induced questioning for other symptoms or findings, she mentioned changes in the color of her toenails. This concerned her, and it had appeared on different toes. On physical examination, she was normotensive, had normal saturation, and a heart rate of 70 beats per minute. The findings she reported regarding her toenails were visible in the photo, interpreted as splinter hemorrhages, which were present on 4 of her toes. The patient had irregular symmetrical pulses. On physical examination, her extremities were warm, with no changes in temperature or color. Lab results showed hyperglycemia with no previous history and a significantly elevated hemoglobin A1c. Her renal function was normal, cardiac enzymes were negative, and there was a considerable window of nearly 12 hours, and without leukocytosis. The ECG done in the emergency room was normal despite the patient being asymptomatic. The chest X-ray was absolutely normal and showed no significant findings. At that time, considering the diagnosis of diabetic onset from significant hyperglycemia and high hemoglobin A1c, we decided to admit her for evaluation and treatment. The chest pain did not come back, the enzymes were negative, repeated, and still negative, and the ECG remained unchanged. This picture of the subungual splinters was interpreted as a probable peripheral embolism, which was decided to be studied in the context of diabetic onset. A transthoracic echocardiogram was requested first, which showed no abnormal findings. It was decided to advance to a transesophageal echocardiogram for study, to investigate this finding and check for any cardiac source. When performing the transesophageal echocardiogram, the aortic and mitral valves were normal, with normal opening and closing. No mobile masses were observed attached to any of the valves. What was observed at the end of the study was a rounded, mobile, pedunculated mass in the descending aorta, 10 centimeters from the origin of the subclavian artery. A mobile, pedunculated mass, round in shape, measuring 13 by 11 millimeters with smooth edges attached to the aortic wall, without any atheromatous plaques in that region. It was the only positive finding, which was quite surprising at that moment, as there were no other notable findings. A resonance imaging was planned to evaluate the whole aorta and to histologically characterize this mass. That was identified in the descending aorta. In the magnetic resonance angiography, we observed that it was an image adhered to the wall of the descending aorta above the diaphragm, 5 centimeters from the diaphragm. It was observed to be pedunculated, showing great mobility, and in histological characterization, it was isointense on Ti, hyperintense on T2, did not enhance with gadolinium, and the aortic wall was not affected. This interpretation led to determine that it was probably a thrombus. About the patient's evolution, anticoagulation was started due to aortic thrombosis found with intravenous heparin. And during the stay, the switch to acenocumarol was started. The treatment for her recently diagnosed diabetes was also initiated. During her stay, she experienced dizziness and mild dysarthria while a family member visited. It was a transient episode lasting just a few minutes. Consequently, an MRI was performed, and it was identified that she had a finding compatible with a stroke in the posterior fossa at the level of the cerebellum. A CT scan of the abdomen and pelvis was performed to look for other areas of thrombosis or embolism, which found no embolic sites. A tranesophagel echocardiogram was repeated 14 days after anticoagulation to evaluate the evolution of the thrombotic image in the aorta, and it was observed that this mobile image had disappeared at the level of the descending aorta. She was hospitalized for 16 days until she reached therapeutic anticoagulation levels with acenocumarole. She then progressed favorably and did not experience any episodes consistent with a cerebrovascular accident. She was assessed by hematology, keeping in mind that she was on anticoagulation. No thrombophilia was detected at that time. An evaluation for anticardiolipin and mutation was performed. Homocysteine, folic acid, and vitamin B12 levels were evaluated, and the truth is that no specific cause for the patient's thrombophilia was found. And it was decided to discharge her on acenocumarole anticoagulation. 1 year after that hospitalization, the patient remained anticoagulated within range on subcutaneous insulin treatment with a glycosylated hemoglobin of 5.8. She had no new embolic events. She reported a slight dizziness that persisted after the cerebellar embolism episode, and she was receiving treatment for hypertension with good control of her blood pressure readings. In truth, it was a case that represented a diagnostic challenge because in the context of diabetic onset, it was interpreted that the patient had this thrombosis on a healthy aorta, which did not show any atheromatous lesions in its wall. The other arteries also showed no atheromatous lesions in the later Doppler evaluation, neither in the carotids, nor in the abdominal aorta, nor in the aortoiliac axis, nor in the femoral arteries. And it was interpreted that this thrombosis had likely occurred due to a thrombophilia generated by the onset of diabetes. We carried out a comprehensive literature search that we will now show to see if similar cases were documented in the literature for a patient who did not have any other cause or thrombophilia described until then. Another major question was how long to keep the patient anticoagulated, considering that her diabetes was now controlled and she had not experienced any further embolic events. But on the other hand, she was a young patient who had tolerated the anticoagulant well and had experienced a significant enough episode to justify her anticoagulation for at least 1 year. The occurrence of subungual splinters is rare since it is not typical. Peripheral embolisms are more typical of endocarditis, but this patient did not have infectious endocarditis or any other condition that would explain it, and it was interpreted that maybe all was connected. In a tomography done during the patient's follow-up, we can see that the aorta persisted without thrombus. It was done with and without contrast, and we can see that the patient did not present parietal calcification later at the site of the thrombosis, which has been reported in some case series, as we will discuss next. Patients with calcification at the aortic wall where thrombosis was present. Moreover, we can also see that in the angiotomography, the aorta had a normal diameter and no other sites of thrombosis were noted. In terms of literature on similar cases, we can see a series of cases published by the Val de Hebron group, headed by Dr. Gustavo Avellano and Dr. Arturo Evangelista, in which they detail 4 patients who were admitted with suspected acute aortic dissection, in whom the tranesophagel echocardiogram allowed for the differential diagnosis of aortic thrombosis. In these cases, signs of peripheral ischemia were observed both in the legs and in the left arm of one patient. Most of them were young men with few risk factors. 2 were high blood pressure patients, 2 were smokers, and 2 had dyslipidemia. All 4 patients were discharged with warfarin and aspirin or clopidogrel for long-term treatment. The mobile thrombus had been reabsorbed in all 4 cases by the 6-month evaluation, and atheromatous plaque was observed at the site where the thrombus had been present, which is what we mentioned earlier, which we have not yet seen in our patient. Next, we have another series of cases, this one by Dr. Cañadas, also from Spain, where they did a meta-analysis of different cases of aortic thrombosis, where we can observe that most are young patients, many of whom are hypertensive or tobacco users. There were histories of aortic thrombosis associated with peripheral ischemia, for example, in the legs. In some cases, we see areas with atherosclerosis and atheromatous plaques, while in other patients, it is not described or they had a normal aorta in that area. Regarding the treatment we were interested in to decide how long we would keep the patient anticoagulated, most had started treatment with sodium heparin infusion, followed by oral anticoagulation, but in many series it was not specified how long they had remained on oral anticoagulation. Therefore, we decided she should have at least 1 year of anticoagulant treatment. The patient is currently 2 years post-episode, still anticoagulated, and the decision to stop anticoagulation is yet to be determined. Indeed, in young patients with embolic events, primary aortic thrombosis is a very uncommon event, but we need to take it into account among the possible causes. Because of its low incidence, the duration of oral anticoagulation in these patients is not yet clear, and we know that uncontrolled diabetes mellitus increases thrombotic event incidence, as it elevates platelet adhesion, activates the clotting factors, and worsens fibrinolysis. And this might have been the triggering factor for aortic thrombosis and embolisms in this patient, who really consulted about an episode of chest pain, which was interpreted as atypical and likely not a coronary embolism, since there were no enzyme curve changes, no changes in the ECG, and no motility changes in the left ventricle by echo, which was probably atypical pain in the context of fatigue and her diabetes onset, which led to the diagnosis of aortic thrombosis. Thank you very much. It is a pleasure to present this case in Aorta Hub.